Welcome, and thank you for standing by. At this time, all participants have been placed on a listen-only mode until the question-and-answer session. To ask a question, press star 1 on your touch-tone phone. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the conference over to Zakiba Henderson. You may begin.
Good afternoon. My name is Zakiba Henderson, and I'm an obstetrician gynecologist and medical epidemiologist in the Division of Reproductive Health at the Centers for Disease Control and Prevention. I lead the state-based Perinatal Quality Collaborative Program here at CDC, and I'd like to welcome you to the third presentation in a series of webinars we are sponsoring on Perinatal Quality Collaboratives. Today's presentation is about perinatal performance measures, and this webcast will include a discussion of identifying and choosing performance measures, data collection sources, and real-time data feedback systems. Our presenter is Dr. Elliot Main. Dr. Main is the director of the California Maternal Quality Care Collaborative, also known as CMQCC, and is the chairman of the Department of Obstetrics and Gynecology at California Pacific Medical Center in San Francisco. He also chairs the first ever California Pregnancy-Associated Mortality Review Committee. Throughout his career, Dr. Main's clinical work and publications have focused on medical complications of pregnancy and outcomes-based quality improvement. Since 1997, he has also led the OB quality improvement for all of Sutter's Health's 20 hospitals and 40,000 births, and developed and led several large-scale data-driven quality improvement efforts in California. He has authored 2 national maternity quality toolkits, Improving Response to Obstetric Hemorrhage and Elimination of Elective Deliveries under 39 weeks, which was co-sponsored with the March of Dimes. Dr. Main has been actively involved in multiple state and national committees on maternal quality measurement, including the National Quality Forum, ACOG, AMA, the Joint Commission, CMS, and the RAND Corporation. He also co-chairs the National ACOG Initiative for Standardizing Obstetric Definitions called Revitalize, and chairs the ACOG Study Section on Reducing Maternal Mortality. At the end of this presentation, you will have the opportunity to ask questions and participate in the discussion. Handouts for this presentation are available for download and printing by clicking on the Handouts icon at the top right corner of the Microsoft Office Live Meeting webpage screen. This presentation will also be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. I will now turn the presentation over to Dr. Elliot Main.
Good morning from California, at least. Thank you, Kiva, for the introduction. This is a topic near and dear to my heart, which is how we can measure performance or quality in obstetrics and then help it drive quality improvement projects, both at the hospital level, at system levels, and now we're doing it in as many states as we can for statewide quality improvement projects. What I'm going to be talking about today is what are the current perinatal and maternity care performance measures. We're not going to go in much detail about NICU performance measures, but I will cover a number of neonatal ones that overlap between obstetrics and pediatrics. And then we're going to talk about using performance measures for QI projects, including data quality improvement, which is really, really important. And then the different sources of data that are largely available to us, and then how those can be integrated together. I have no disclosures other than that Kiva pays me partly here through a CDC grant. Let's start off with a discussion of what the landscape of quality and safety is. This is a very famous landscape in California, Yosemite Falls. Every state has a beautiful landscape. For quality, though, it's very crowded a landscape. We started off years ago with risk management issues for quality and focused on shoulder dystocia, oxytocin safety, vacuum safety, teamwork, and communications as really a focus for reducing risk on labor and delivery. ACOG and others identified some quality indicators that are used for chart review for peer review. What we've done in the last decade is move beyond peer review to really look at quality metrics. And these would include both outcome measures. An outcome is usually a morbidity or mortality. So maternal mortality is used state and nationally. It's obviously too rare to use at the hospital level, or even for many states for that matter. There's a lot of interest in severe morbidity, both maternal morbidity and infant morbidity, and we're going to talk about some of those measures toward the end. But a lot of the interest and focus has been on process measures. These are much easier to measure. They identify a process of care that we hope is going to be linked to an outcome, and that linkage does need to be established. But these would be things like antibiotics before C-sections, venous thromboembolism prevention. There's 2 leapfrog measures on those, for example. Antenatal steroids for preterm labor patients. That's been a quality measure almost from the beginning in maternity care. Other measures, though, and this is where some of our measures fall into this other category, and these would include utilization, over and underutilization, measures for access, and measures that can detect and help drive improvement in disparity. But we're not done yet. The landscape fills up even more. All of these measures can vary on the level of release. Some of these can be released publicly, some are used confidentially or even internally benchmarking level, and we have actually do that within our collaborative. At sort of the top of a pyramid, our public release measures, a lot are done confidentially, where hospitals share among themselves with or without identity, and then yet others are used for driving quality improvement internally. The level of measurement is also one that we have to look at these measures for. Some are hospital level, some are medical provider level, some are medical group level, and even more, and there is still some that are population, like the Healthy Person 2020 measure set. What's also in the mix now is Joint Commission's requirements that we do reviews for sentinel events, and then a series of acronyms that are well known to people who work in hospitals, but unknown to people who aren't hospital-based. These are root cause analysis, failure mode effects analysis, and the 2 that are getting very much interest is the Joint Commission has mandated that every provider be measured 6 monthly on at least a 6-point scale called Ongoing Physician Performance Evaluation, or OPPE. This is a Joint Commission criteria, and for OB, we're adapting some of the measures to fulfill that need. And FPPE is a focused one if there's a concern about a specific provider. And then lastly on this busy landscape is ways of looking at no harm events or near-miss analyses. I think these are going to be very fruitful as we look for quality improvement, because they are much more valuable and much less emotion-laden than looking at a case that had a severe complication. So if you can identify a near miss, you can focus on the processes that led to that and then improve care. So that's the landscape. And what we're going to look at today is some outcome measures, some process measures, some that are publicly released. We're largely looking at hospital level measurement, and we're largely, and a few that are population, and we're also looking at some utilization. Utilization would include things like C-section rates, which doesn't quite fit a process, doesn't quite fit an outcome. So we're only looking at a segment of the landscape here today, and that's the message I wanted to leave. Now, when you look at maternal QI projects, as most of you are undertaking in your states or in your systems, there's 2 really different drivers for QI activities. One is, are you trying to improve a specific quality of performance measure? One that has become a national measure now is elimination of elective deliveries under 39 weeks. CMS has now mandated that that will be reported as of July by every hospital in the land, beginning with January 1, 2013 births. So we have till July to get that organized, but that's going to be reported to CMS in July, starting in July. Other examples of quality measures that we have QI projects on would be increasing antenatal steroids. Several statewide projects are working on that, and reducing low-risk first birth cesarean sections. A number of folks are gearing up for that one. But the other driver, which is also important and one we've done a lot of work in as well, is working on improving safety and reducing maternal morbidity on labor units. And the two examples that are well fleshed out now are enhancing the response to obstetric hemorrhage, which reduces the morbidity from hemorrhage, and we'll talk about that briefly, and improving response to preeclampsia, which is a project that ACOG is working on nationwide, and we in New York are developing toolkits for implementation. So for years, CMS had developed a set of adult measures for the Medicare population. But Medicare doesn't pay for moms and babies, so there weren't really national measures, quality measures for that are reported to CMS in the last 10 to 20 years. But now in the last 3 years, and I'm going to go through these, everybody is getting on the bandwagon that they really have a need, and I'm strongly supporting of that, of course, for measuring outcomes in maternity care, for obstetrics and nursery care in particular. This is real important because all the commercial payers have followed CMS in using the same measures for, quote, adults. Of course, women are adults, but they're, again, not in that because they're not in that age range. And that's where all the attention is, okay? So because if we have a set of measures that CMS embraces and the commercials follow, then those become really the playbook for quality improvement in the land. So let's talk about the players here for a moment. The National Quality Forum is really the big kahuna, so to speak. It vets all quality measures for most all other organizations, and it has a mandate from Congress to do this so that if the National Quality Forum approves it, government agencies can adopt these measures without further government review. Very important step because government review takes literally several years. So this is a joint public-private venture, the National Quality Forum, based in D.C., and it involves experts from around the country and a lot of stakeholder involvement at many levels. We're going to hear more about NQF going forward. The Joint Commission is the hospital accreditor for over 90% of hospitals in the United States, and has become a major proponent of quality measures, and we're going to talk about the Joint Commission at length here. Leapfrog Group is an employer group that drives public reporting of quality measures. It's, you know, what are we getting for our bucks kind of viewpoint for employers. CMS is now in the game, both because Medicaid is recognized pays for 50% of the births in the United States. Some states about 45, some states much higher than 55. But overall, about 50% of the births in the United States are paid by Medicaid. And now Medicaid has clearly identified that they need some quality measures for, like the payers, the purchasers, so the employers above, they want to have some quality measures for what they're paying for. AMA, in combination with the specialty groups, in this case ACOG, has a Physician Consortium for Performance Improvement, or PCPI. This is a program that develops actual physician or provider level metrics, and they have gotten into this game in the last year and a half as well. Lastly, and I didn't put it on the former list because this is really a focus on health plans, is the NCQA that does HEDIS measure sets. And they have 75 measures across 8 domains that basically every health plan in the United States does report to. They don't have a lot in maternity care, because they're focused on outpatient, not inpatient. But their focus has been on timeliness of prenatal care and frequency of ongoing care and the postpartum visit at the end. And it's basically tick marks. They haven't looked at the content or the quality of those visits, just did you have those visits at a timely way. So NQF, this is part of their mission statement. Their goal is to set national priorities and goals for performance improvement and develop consensus standards. It's a not-for-profit, multi-stakeholder group. In 2008, they established their first ever committee. They've been around a while, but we were not the first, the second, or the third group that they looked at, but they got to us in perinatal care in 2008. A set of experts, they looked over 33 measures, and these were the kind of criteria that are used for all NQF measures, that it has to be important, which means it has impact, opportunity, and evidence behind it. Reliable, which is actually there are reliable studies showing that reliability testing showing that if the measure says something, it is reliably saying that, and it's not likely to be off by more than a minimal amount, and that there's validity, that these make sense, that they're credible to users and to the public. Thirdly, that it has to be usable, it's practical, that it can be collected, and that people can understand it, and that also goes into feasibility. So, out of those 33 measures, they did adopt 17, of which 9 are in our obstetric realm here. And I've divided these into 5 that really have to do just with the obstetric care of the mother, and 4 that are overlap into the baby side that have obstetric fingerprints on them, such as antenatal steroids, delivering under 1,500 gram babies at a level 3 center, and exclusive breastfeeding, where we have certainly a lot of educational input on. So these were adopted, and then, by the NQF, and then the Joint Commission got in the game, and they had a panel of experts a year later that then picked from this menu. And that's going to be a theme going forward. The NQF sets up a menu, and then other organizations pick from that menu. So here's the NQF menu again, and these are 4 of the 5 that the Joint Commission picked. The 5th one was bloodstream infections in NICU patients, not on this list. So they picked 2 that were elective delivery under 39 weeks and cesarean rate that were mom-directed, and 2 that were baby-directed, exclusive breastfeeding and hospital discharge, and the rate of antenatal steroids initially under 34, and they've since refined it to under 32 weeks. Leapfrog picked from the same menu, and there's overlap here. They actually identified DVT prophylaxis, and they also picked one that wasn't on the list, which is bilirubin screening, which is on the baby side of the NQF list. A lot of Medicaid organizations around the country looking at measures have really focused on these, identifying these of what they feel to have the highest value, i.e. quality and savings. So that's elective delivery under 39 weeks with savings in NICUs, cesarean rate for low-risk first births, which makes a big difference if you move the C-section rate in a hospital from 45 or 50% down to a target of 25 to 30%. And we're going to show some of those rates in California. And then under 1,500 grams, babies not delivered to level 3 center. States vary quite a bit on this one. So I'm going to go over the Joint Commission measure set because that's the one that is front and center for, as I'll discuss in a moment, for every hospital in the country right now, as this set will become mandatory next year. So the first one is elective delivery under 39 weeks. And it's actually really 37 to 39 weeks, just to make it a little cleaner measurement. So 37.0 to 38.6. On the numerator is those with elective deliveries, which means they do not have a medical or obstetric indication from a list, a standard Joint Commission list that was developed with a group of experts taken from ACOG lists and has in the last year and a half, as this become operational, they've continually added some codes and then identified that there were some conditions that did not have codes that they felt were added, which is good, but adds to the collection burden, as we'll talk about. And that includes C-sections with a prior classical incision or myomectomy. This is a widely used resource for this that we developed in California with the March of Dimes, and is being our slide set for this was just upgraded a month ago, reflecting new important data. The second measure that the Joint Commission has in its core measure set, is also an important one for obstetric practice, which focuses on women having their first birth, nulliparous women, at term with a singleton baby in a vertex presentation. So it eliminates all twins, all preemies, all breaches, things that have very high rates of C-sections for their, and with often a good indication, and focuses really on moms in labor. And we're going to show that's where the big variation is. We are actually working with the Joint Commission. We have a few adjusters, and that would include maternal age and probably maternal obesity and degrees of obesity. But that's coming. Here's a little bit of data indicating that the vast majority of inter-hospital variation in overall, but particularly primary C-section rates, is attributable to this population. Again, nulliparous term singleton vertex. And well over half, 60 to 70% in other studies, of the rise in C-section that we've seen over 10 years is attributable to this population. So this is the key population. When you look at the indications for C-sections and what is the proportion of these indications over here for the overall C-section rate, you can see that abnormal labor, dystocia, failure to progress, is a significant portion of overall, as is the in quote diagnosis of fetal distress, which is abnormal fetal heart rate tracings. These are the two biggest ones besides repeat C-sections. So we look at primary. These are the ones that drive it up to 60–70% of all primary C-sections is in this group, which is labor, and this is the target of that measure. And these have very variable rates. Breech presentation, for example, in the United States has over 98% C-section rate. We're not going to change that. That shouldn't be part of a quality measure, for example. So this is where the action is, and this is the focus of NTSV C-section rate. This is the variation that is seen not just at the hospital level. In California, when we look at hospitals level data, we see hospitals as high as 50% and as low as 15% on that measure. The Healthy Person 2020 target is 23.9%, seen in the label over the left. That's the black line in this slide. This is the 11 perinatal regions in California. So this is a roll-up of our 280 hospitals in California that deliver babies into 11 categories, regional categories. And you can see very large regional differences both in the NTSV C-section rate in blue and the total C-section rate in red. You can see regionally, this first region, which is my hometown, does actually quite well, even though we have much older moms in the Bay Area, with very low NTSV C-section rates below the national target, and a total C-section rate on this measurement year of just over 25%. That's reflected in category or region number 10 here, which is Kaiser Permanente North, which also has low NTSV C-sections and total C-sections. You go down to the middle bars here in the LA region, and it's a very different story. The same state, same malpractice environment. different cultures in the hospitals. C-sections is not an easy one to solve. There's going to be a lot of work that's being done actually nationally. There's been a consensus conference from NICHT and CDC and ACOG and SMFM working on this. They have published their data. We've given ideas in a Green Journal article in November that went along with the NICHT article. ACOG is taking some leadership role in this. There's a Choosing Wisely campaign that just came out a few days ago that I would draw your attention to. And there are several toolkits that are being developed that will be available in a few months on this topic as well. LA County I'm working with here, and they're developing a number of tools and a big project for LA County. The third performance measure for the Joint Commission in their core measure set is antenatal steroids for moms at risk of preterm delivery at 24 to 32 weeks. Now, everybody should recall that the ACOG guideline is up to 34 weeks. But ACOG did put a caveat in there that it was controversial if there were ruptured membranes between 32 and 34 weeks. And in their wisdom, the Joint Commission says, well, if there's to make the measure cleaner, we'll just do 32 weeks. We don't have to worry about identifying who's ruptured and who's not. So that's why it's 24 to 32 weeks. This is different from the Vermont Oxford, which has been around for a lot longer, but that's focused on babies under 1,500 grams. And there's actually a fair number of babies between 1,500 grams and 32 weeks. The Joint Commission is mothers is the denominators, Vermont Oxford is babies. So there's some differences there as well, obviously for multiple gestations. Antenatal steroids is something that we shouldn't have to be dealing with in 2013. The first studies on this came out in the 1970s, Liggins and Howe. And there were 40-odd randomized controlled trials in the 1980s. And here's data in 2010 from all the California NICUs. And there is a huge variation of care seen in CPQCC, our sister organization, the Neonatal Quality Improvement Collaboratives, that the mean is about 85% for the state, but you see a lot of hospitals under 70% and a few under 50% use. The ones that are starred are fewer than 25 infants, but nonetheless, people should be above 90% on this pretty routinely. So we're going back, and several states are doing quality improvement projects on this very basic intervention that has major quality improvement actions on preemies. So some of the nice resources are from CPQCC, which can be reached either through their website, cpqcc.org, that's a typo there. I write CMQCC so often. And then the Ohio Perinatal Quality Collaborative has some nice resources on their website here. They're taking this up as a statewide project right now because they have even lower rates of utilization. The last of the 5 core measures, and this is the 4th maternity one, is exclusive breastfeeding. And this is an interesting one because the rates of exclusive breastfeeding, i.e. no formula during the birth hospitalization, varies tremendously as well. We have some hospitals in data that I have access to in California, statewide data. Some hospitals in California are up in the 80 to 90%, and other hospitals are at the 15 to 20%. And that's a huge opportunity. And the driver here is that if you get your breastfeeding established well and you want to breastfeed, you you have to get it established well in the first week of life to get it going, and a number of studies have shown that if you have the baby at the breast and are giving the baby formula at the same time in the first 3 or 4 days of life, your success for breastfeeding is much less. And there are a number of hospital practices that happen often at night where that don't favor exclusive breastfeeding, and that's what this is focused on. This measure has been tweaked in the last 6 months so that it will be calculated with 2 denominators, one that is all mothers and one is mothers who, only mothers who want to breastfeed. So it will be able to satisfy the critics that said, well, we don't want to be forcing moms who don't want to breastfeed at all into this, which was not the intent, of course, at all. Obviously, there are exclusions for maternal medical conditions for which breastfeeding should be avoided, like HIV, a few others. That's a very small list, though, when all is said and done. So, a couple things about what's coming. The AMA PCPI that I mentioned earlier is the process for provider-level reporting. There are 10 measures that got out of that committee that are currently under testing currently. The second item that's coming is a measure that NQF approved in a pediatric session, not the maternity session, but is a maternity focus, which is looking at healthy term newborns. So it's a composite measure of neonatal morbidity, and I'm going to talk about that in a moment. And then lastly, what we really need and don't have yet is a composite for maternal morbidity. There's increasing attention to how we can look at reducing maternal morbidity and mortality. It's the hemorrhage I was speaking of earlier and preeclampsia. The CDC has published several articles looking at using IC9 codes or length of stay, and we're actually evaluating those in California. So we're going to have to put a hold on that and see what happens there. So the AMA PTI process. This is multi-stakeholder, multi-organizations, again, looking at this. And they're focused on the IOM's 6 aims for quality improvement, safety, effective. It has to be safe, effective, patient-centered, timely, efficient, and equitable. So these measures were developed with that in mind. These are the 10 that are currently under testing that would all be amenable at some of these hospitals, but certainly provider levels. And this was not only looking at the outpatient care, not just whether people showed, you could tick off the visits, but what's the content of the visits? What is the content of prenatal care? When we examine that, the important elements of the content fell into these 4 areas. One is that you need to establish your best obstetric gestational age before 20 weeks and have that charted in a prominent place in your prenatal record. Often this is by ultrasound. Secondly, that you have key screening tests done. This is pretty routine, but there's some elements that aren't being done routinely, like HIV, that is a strong recommendation from ACOG. Likewise, universal GBS screening in the later part of pregnancy. And the 2 others are behavioral risk assessments and BMI assessment and weight gain recommendations. For the hospital or the birth setting, there were 3 of the NQF measures were just taken lock, stock, and barrel for provider level, which is elective delivery, C-section for nulliparous women, and episiotomy. There was 2 newer measures. One is to provide women an assessment of the proportion of births that occur spontaneously. So this is i.e. without induction and without a vacuum forceps or C-section or an episiotomy. And then lastly, this care coordination is an interesting one. Care coordination is a big issue in obstetrics because there are a lot of handoffs from outpatient to inpatient and back to outpatient again. Care coordination is simply, was your prenatal record available when the mother came in to be delivered? Prenatal record is including all the laboratory tests above, the best EDD, and any other key information. That varies from hospital to hospital. Some places this is a really big issue and leads to the repeat of laboratory tests or delays in care, and it's just poor form not to have the prenatal record available when you go in to deliver. And then lastly, instead of just a postpartum visit, what is the content of that postpartum visit, and defining what should be done, and therefore what can be measured. And the content that the experts I settled on was breastfeeding. That visit should include breastfeeding evaluation, depression screening, and family planning. And if the mother has glucose intolerance during pregnancy, that she be set up for glucose screenings at the 6 to 8 week mark. So these are under testing. Not all of these will make it out the gate, but I expect a good number of these will. Obviously, the outpatient ones is going to involve some chart review. And that's a burden. We're working up so that the hospital level ones can be developed with administrative data as we collect the hospital level measures on the same metrics. One of the key outcomes that when you ask mothers that they're most interested in is having a healthy baby at the end of the day. C-section rates may be important, episiotomy maybe have some importance, but the most important thing to a mom or a family is to have a healthy baby at the end. And we've not had good measures in that area. And this would be a balancing measure for C-section rates, for example, or other obstetric outcomes. This was improved by NQF. This is a measure that we've actually been working on at CMQCC. We've actually expanded it, tweaked it, and used it now for about 1 million births and made some very nice corrections in it will help drive QI. Essentially, it looks at babies of mothers who come in without pre-existing conditions. So babies without pre-existing conditions. And when we talk about pre-existing conditions, we're talking about birth defects, intrauterine growth retardation, isoimmunization, or mothers with drug withdrawals, or preemies, or twins or triplets. So all those are excluded. So we're just looking at very straightforward, simple term babies. And then asking whether those babies had very low APGARs under 3, died. There's very few actually in this group that had neonatal death. Transferred to a higher level of care, so it's a separation of mom and baby, a big dislocation for most families. Or had a diagnosis or procedure code for a major birth injury or neurological difficulty, such as intracranial hemorrhage, HIE, which is hypoxic ischemic encephalopathy or birth asphyxia, Erb's palsy, RDS, being on a ventilator. So there's procedure codes here as well as diagnosis codes. And that's an important thing to keep in mind because sometimes people don't code all of the diagnoses on administrative sets, but they are much more likely to code procedures. We divided this into severe, as I just enumerated, and moderate. And the moderate are those that have a lesser diagnosis, but essentially result in a longer length of stay than usual. So the baby stayed longer than the mom. And they had other types of morbidities, such as being on CPAP, having other lesser birth injuries, but again, having a longer length of stay. So minor birth injuries that the baby goes home in 2 days doesn't really bother the mom or us and aren't on this list. We also had a category of babies that stayed a really long time, like greater than 6 days, but really they didn't do a good job of coding why this baby was there. And from this list, these were also put into the moderate category. From this list, we excluded babies that were there for jaundice or Billy lights, either, again, diagnosis or procedure, or social reasons, like baby up for adoption. Again, we've excluded drug withdrawals. And so this is a way of balancing the administrative data sets to to look at both procedure or diagnosis codes, and to avoid undercoding and overcoding by looking at length of stay and having that be part of it as well. So this is actually being rolled out, and it's going to be a number of manuscripts for press on this one, and so I would pay attention to that going forward. So as I mentioned at the beginning, these are now front and center. CMS announced a few months ago that the measure early elective delivery with the Joint Commission specifications will be mandatory to report by all hospitals as of July 1, which is 3-4 months, and will be part of their value-based purchasing program, also a pay-for-performance program as of January 1 next year. The Joint Commission also announced in November that their perinatal core measure set will be mandatory for all hospitals that are Joint Commission hospitals. That's over 90%. Mandatory to be reported with if you have over 1,100, that's a typo. So 1,100 annual births starting next year, January 2014. It is not too early, shall I hasten to advise, not too early to start working on your data collection. Joint Commission measures aren't that easy to collect data for, and you want to clean your data and clean up your processes this year prior to the mandatory reporting. It is expected that after a year or two, hospitals under 1,100 will also be asked to report as well. In other programs, the state Medicaid offices are also looking at having quality dashboards in almost every state. And since Medicaid pays for half the births in almost every state, and that births make up a very large proportion of Medicaid expenditures, probably at least a quarter to a third, states are very interested in active OB measurements and reporting programs. So, picking the right measure set. You want to have more than one measure. You'd like to have a basket of measures. But what goes in that basket? Because you want to have, each measure identifies a certain direction or certain focus of care, and you want them to look at multiple focuses and things that balance each other out. So here's the set of balances. You don't want them all outcome, you don't want them all process measures. On the upper left, outcome measures are things that you really think of are really good things to improve, but they're actually often pretty uncommon in maternity. And that makes them somewhat harder to improve. So you want to balance those with process measures, ideally, that are linked to those outcomes, that you can focus on and say, okay, short term, everybody gets antibiotics prior to C-sections or things like that. Secondly, on the right side then, you want to have things that the public really is excited about, but you also have to balance that with the burden of cost to collect the measure. And we're going to talk about timeliness here too, and the burden of doing it with a rapid cycle mind. Thirdly, on the far left here, this is a Goldilocks situation. You don't want too many measures because that dilutes quality improvement attention at state and at the hospitals, but you don't want too few. So somewhere in the 3 to 6 range, and 4 to 5 is probably where people are going. Ideally, you'd like inpatient measures and outpatient measures. Maternity care obviously happens for a long time before the birth itself, but the birth is the major outcome of the maternity process. You want to be able to push the measures out, get them right out there, but you also measures that push care, directly improving care, but you also want to have balancing measures that pick up unintended consequences of those measures that push care. Additional considerations are, it's got to be reasonably accurate. And this is something that we're seeing with the Joint Commission measures set, as the Joint Commission has allowed for sampling. And you've got to be really cautious about sampling, particularly if the outcome measure numerator is small, because you can get distorted numbers if your sample size is relatively small. So sampling is tricky. We run into issues with that with elective delivery under 39 weeks, where if you sample and only look at 60 charts, you'll get numbers that vary just too greatly. Again, feasibility is related to sample size. Sample size then, and the cost of doing data collection, since we're interested in the birthing population, we're looking at much bigger samples potentially if you do the whole birth population than other quality measures in other areas. For example, looking at acute MI patients, that's in the hundreds, where in a big hospital, births can be in the many thousands. So this has led to a lot of attention to the role of administrative data versus simple chart review. And we're going to talk about ways of doing hybrid ways of looking at data. It's where you narrow down the cases using administrative data for ones that need some additional chart review. That again, that raises the feasibility, reduces the cost. Now quality measures are being looked at not only at the state and nation level, like Healthy Person 2020, but also at the health plan, at the medical group, at the hospital, and the provider. They're going to have different measures in these environments and different measure sets. And then, as we said in the very first slide, where we use these performance measures, and our choice is going to vary whether we're using it for internal quality improvement or whether you use it for public reporting or even pay for performance. You're going to have different sets. For example, the accuracy needs to be extraordinarily high to use for pay for performance. You want as broad as possible data collection for public reporting. On the internal QI, you're willing to accept a little bit more vagaries and do chart review for that, but it's not going to be, you still don't want to have too much burden to do that, but it doesn't have to meet the same standards as pay for performance does. So examples of balancing measures would be pairing the NTSV C-section rate with unexpected newborn complications or the healthy term newborn. So you want a baby measure with a mom measure if you're trying to push the care of the mom. So let's turn and talk about maternal mortality and morbidity, how those can be turned into quality improvement projects. This is a schematic. This is a summary of multiple studies of U.S. maternal mortality data as to what the overall causes of mortality are in the United States. If you were to lump them, the top 5 causes, cardiac disease has emerged as the most common category, of which 2/3 is cardiomyopathy. African Americans are higher in this group than others, and this is part of the contribution toward the racial disparity. But the next 2 categories are ones that we've been working on quite a bit and have well-identified toolkits for, which is obstetric hemorrhage and preeclampsia. People die from preeclampsia from strokes, and a little bit from liver failure, but it's mostly strokes from poor blood pressure control. And then the top 2 are infection and venous thrombo and embolic disease, either venous thromboembolism or amniotic fluid embolism. Now, when you look instead at mortality at ICU admissions, and this is again a composite of multiple studies, you start getting a different size of the pots here, so that hemorrhage is now a bigger contributor, as is preeclampsia, and cardiac disease falls, and the embolic disease falls. And when you look at measures of overall severe morbidity, Again, the contributions to the buckets change, and hemorrhage is preeminent. Serious morbidity is defined a whole variety of ways, and this is a composite. But obviously, as you look then going forward, the biggest causes of morbidity in the United States in pregnant women is hemorrhage and preeclampsia. And that's where we've chosen to do our quality improvement projects first. As we have looked at doing the measurements for that, and we felt that it was probably, at the end of the day, we're going to need some composite measures. This is a good reference for a toolkit for best practices for hemorrhage. It came out 2 years ago. A series of brief best practices as well as guidelines and checklists to do. This has been actually translated into Spanish. It's actually being translated right now into Russian for sort of my personal favorite. I want to see this in Cyrillic, but for use in a variety of the Russian republics. And it's being modified and used in other states around the country. It will need to be modified to fit local needs, of course, but it gives a framework of how to approach hemorrhage, and a framework is the critical part of the deal. Interesting, though, when we've run hemorrhage collaboratives, and we've run 3 or 4 large-scale collaboratives with 20 to 30 hospitals in California, and gotten a lot of learning from that, and we learn from each other when we run collaboratives. These are some of the metrics that we use within the collaborative. We've tweaked them for each collaborative as we've learned, and I would expect other collaboratives would have somewhat different metrics. But you want process measures. Those might include pregnant women who had a risk assessment on admission, as that's part of the toolkit, is to be aware of women at higher risk, acknowledging that women don't have to have risk factors to have a hemorrhage, but certainly those with risk factors have higher rates of hemorrhage, including twins and prior hemorrhage and polyhydramnias, and then during labor, those who have infection or those who have long second stages are all at significantly increased risk of postpartum hemorrhage. We have emphasized trying to semi-quantify blood loss, either with under buttock drapes or that have gradations on them, or weighing pads and clots, certainly if of anybody that you suspect is over 300 or 400 mLs of blood loss. The outcome measures that we've used are things like the hysterectomy rate, peri or postpartum hysterectomies, and we've divided those into those that were placental related, those are accretus or placenta previous, versus those that were typically just atony related. This has been a great project to engage other departments in the hospital, and the key department to engage here is the blood bank. And the blood bank actually has a pretty rich source of data. Most blood banks are under scrutiny to do QI projects, and they have actually really liked getting involved with the OB department doing QI projects on hemorrhage, and they've been able to give our hospitals a lot of data around things like total blood products used, the ratios of red cells to FFP, and one that I'm particularly focused on isn't so much, if you need a blood transfusion, you need a blood transfusion. We're not trying to reduce that, but we're trying to really reduce the moms who get massive transfusions, the ones that are 5, 10, 15 units of blood. That's where your morbidity really sets in. And so one of our outcome measures has been moms who get 5 or more units of blood. As part of a collaborative, in addition to the process and outcome measures, we also have, quote, deliverables, which are one-off things, that you implement a policy, a general policy for obstetric hemorrhage, or you implement a massive transfusion policy, or fix your hospital-wide massive transfusion policy so it works on labor and delivery, not just the ER for trauma. that you have teaching opportunities and engage all the staff for hemorrhage policy. So these are the type of things that would be deliverables. So these are examples of metrics that you'd use for a hospital-level collaborative. So a general comment about data collection is that the biggest barrier is cost. And cost is basically manpower of chart review, or a little bit for administrative data analyst review. As I've noted, many of the outcomes in obstetrics are pretty low frequency, particularly when you're looking at infant injury or maternal morbidities. And so you'd want to have a way of screening all births for that as much as possible. Birth certificates have been a useful source for a number of collaboratives, but we're going to talk a little bit about data quality, and there are some fields on a birth certificate that are very high quality, and you really want to go there. And they actually offer data that's not available in many other places, such as APGAR scores, gestational age, and birth weight are easily available on a birth certificate, and by and large, reasonable accuracy. We're going to talk about data quality improvement in a few moments. Some states have embraced this wholeheartedly and have engaged quality collaboratives with near real-time data. Other states have held back for their own administrative reasons, but this use of data is now being highly encouraged by organizations like the National Association of Public Health Statistics, NAPSIS, which is the State Association of Vital Records, and is part of a bigger movement essentially called Free the Data, which is to make administrative data accessible for people who can use it to improve care. So let's talk about the data sources for QI collaboratives. In many states, we have a foundation of administrative data sets that allow us to get data on all births and use that as a starting point, a foundation. And the two data sources that may be available in your state, and ideally both, are the birth certificate file, which has the clinical data from that. We don't care, of course, about the registration aspects. This is really good for birth weight parity and plurality, like twins, singletons, and parity is actually something you can't get easily from other administrative sources. Is her first kid or not? It's pretty good, not great, but good for OB gestational age, particularly if you have some QI activity in your state on improving birth record recording of gestational age. There are two gestational ages on a birth certificate, the LMP gestational age and the obstetric estimate gestational age. OB estimate of gestational age is a much tighter, much better one to use. In fact, the National Center for Health Statistics is strongly considering dropping the use of LMP gestational age shortly. That will involve a lot of work in terms of changing targets and everything else, which is why it hasn't happened. But they have identified that the OB estimate gestational age is a much superior number. So we use that for quality improvement projects. Birth certificate, however, is less good for diagnoses. If it's there, it's likely to be true, but it misses a lot. The APGARs is there, and that can be useful. What we have identified is that this pairs up well with the PDD, the Patient Discharge Diagnosis File, which is a list of all the IC9 codes for procedures and diagnoses. It also has length of stay, admission dates, discharge dates, et cetera, and it has disposition, whether the mom, or in this case, or the baby was transferred to another hospital, or whether it died or went home. It also has a little bit stronger paired information. So that's really foundational, and the ideal is to link the two. There are a number of algorithms. We actually have this down that we do this on the fly in California, and so it's immediately linked as soon as we get the two data sets with nice algorithms. So this is the foundation, and what can you build on to it? And this depends on the projects that you're doing. If you are doing elective delivery under 39 weeks, for example, you need a few data elements that are only found in the chart. These would include, for example, if the mother had a C-section 37 to 39 weeks, was she in labor, were her membranes ruptured, or did she have a prior classical C-section? Those are things that can only be found in the chart. Now, ideally, these are being coded or identified in an electronic, as separate fields in an electronic medical record, and that's what is the future, is to do as much of this with structured data in an electronic medical record. But we're not there yet in 90+% of the hospitals. Other data sources can be blood banks, can be billing information from Medicaid programs. They often have some of the diagnosis codes, may not have all of them though, which is why the PDD is a nice addition, but the billing information has more information about outpatient info. PRAMS, which is a survey done in most states. California has its own version of it, as we are wont to do with things. But every state has a version of PRAMS, which is run by initiated by the CDC, and it is useful to coordinate with these other data elements as best as can be done. So let's talk about these two prime administrative data sources. Starting on the right with the birth certificate file, this is has a basic requirement. Your vital records department has to be interested in doing this. See, you got to get them engaged, and you got in the carrot we have used with our vital records department is first of all they didn't need a big carrot. They've got interested in having their data used to improve care. I mean, that's really nice to have that as an orientation. Not only are they a registration, birth and death registration organization, but they want to see their data being used to improve outcomes. So that was a starting point. But what the carrot for them largely is we as folks who work in hospitals have the ability to help the hospitals improve the data. It is impressive how many people within a state organization use birth certificate data for all kinds of state and public health and just overall surveillance issues. So the better that data is, the better all those functions will be. And so we have done or engaged in a major quality improvement project for selected fields within the birth certificate, and then we'll increase those number of fields over time. Obviously, if you're going to use state-gathered data, you have to go through IRBs, and that took a year and a half on average, but it's doable, and now we've gotten it so it's ongoing. An exciting part of this is that this can be near real time. We're getting birth certificate data in California on every birth 45 days after the end of each month. We waited 45 days, and that's when 99% of births are registered. There's always some that trickle in. They're supposed to be registered within 10 days, but some trickle in. So the happy median that we got, they would have given us at 30 days, but at 45 days, we get over 99% of the births. In most hospitals, it's 100%. So that's pretty exciting. Some states that I've worked with have been able to add additional quality improvement questions to the birth certificate. Louisiana has done this, for example, and has done a lot of the elective delivery under 39-week issues just by the birth certificate. My state, it takes an act of Congress to change the birth certificate. Literally, you have to go through the state assembly, the state legislature to change any element of the birth certificate, and that takes several years. And so that's not a practical approach here. But I would like to point out, just because we're changing forms, like changing a birth certificate, doesn't mean that's going to be completed accurately, or completed at all for that matter. So you have to really go through the workflows and the processes of completion and the education steps if you're going to change something like a birth certificate, so that you get reasonable data. So the other side of this slide is the PDD. And here, most but not all states have a central collection agency for all the hospitals to submit their PDD. Sometimes this is a public agency, sometimes this is a private agency, like a payer collaborative or a quality collaborative sometimes runs these, where every hospital submits their discharge diagnosis stuff. This is a hugely valuable source of diagnosis and procedure codes, and you can get both the mom and the baby data. It does revolve IRBs often, but if you're relying on hospitals to send it to a central agency, they typically only send it every 6 months or so, so that puts a delay in. In California, we have arrangements with our central agency called OSHPA, the Office of Statewide Health Planning, to get it every 6 months, but there's a delay. They get it from the hospitals every 6 months. They have to clean the data and then turn it around to us, so that's another 2 months. So we just got the first half of 2012 from the state for every hospital in the state. We have an active side of our data center that actually gets it from the hospitals directly for hospitals that want very timely data, and that's what we're going to show here. So this is the California approach, the California Maternal Quality Care Internal Data Center, called the California Maternal Data Center, and that gets patients' discharge diagnosis and birth certificate files, links them together through algorithm immediately. And then we can turn that around pretty much within minutes to a set of reports for the hospital for every measure that does not require chart review. So for some measures, like elective delivery under 39 weeks, there still are some chart review elements that the hospital can enter through a very nice computer interface for only the records that need the chart review data entered, which ends up being about 3% of the records. So this has been a very nice model, and I'm working with several other states to try and reproduce this with their states, but each state's going to be a little different. Our mantra, though, is, particularly for birth certificate data, is if you use it, they will improve it. If you use it for purposes that the hospital sees of value, then they see value improving the birth certificate data. Conversely, if you never use it, birth certificate data for anything having to do with quality, there won't be any impetus, any incentive, any push to improve the data. So improving and using the data is very important for improving it. So now we're going to talk about data quality improvement for 5 minutes. First off, you need to have standard definitions. And this is the Revitalize project that ACOG, March Dimes, and a whole variety of organizations have started. I have the privilege of co-chairing this. It is to nationally standardize obstetric data definitions and to push for their utilization for all obstetric data elements used for birth certificates, data registries, EMRs, and quality improvement projects. It has engaged pretty much every stakeholder we can imagine. So I have I learned a lot of acronyms in this process, as you can see on the screen. But it involves federal agencies, state departments of health, quality organizations, EMR vendors, payers, as well as a lot of providers, provider groups, midwifery groups, the National ACNM, A1 for nursing, and some large quality collaboratives. So this is a project that is actually coming to close. It has been out to public comment for about 70 new standardized definitions, and we are working on taking the public comments and tweaking the definitions. This should be published later this summer. And ACOG is going to be pushing this real hard with their stakeholder groups. So stay tuned on this one. So there's 5 elements that we think are important for maternal data quality improvement. We've talked about standardizing data definitions, which is a national project underway. The second is educating the providers, the coders, and the birth clerks. Those are the 3 people that deal with data in hospitals. So the providers have to know, you have to document, first of all, and that's a piece of work, getting actually the diagnosis in the chart to begin with sometimes. The coders have to keep up with new codes that go along with these quality measures, and we're working with some national and state level coding associations on that. And the birth clerks. The birth clerks in California and several other states are targets now of educational programs about the importance of the data and how to chart correctly in the birth certificate what a presentation is, for example. A lot of confusion among occiput versus vertex versus cephalic, just as an example, and that leads some birth clerks to write other. When they all should be occiput or vertex, depending on what your birth certificate says. They're all the same. We have been focusing in California on that issue, but also on gestational age. We're developing a toolkit around gestational age, taking it from the office through the hospital, through the birth certificate. For any quality improvement project, for any of you who have done QI work, you realize that it's only partly about the people, but an awful lot about the systems. And there's opportunities for systems redesign here. And I think this is where you get a big bang for buck, but it's actually a piece of work as well. You want standard locations on a chart for key data, particularly things like gestational age, should be in a standard spot where everybody can go and find it. We're getting work groups together to work with the EMR vendors, because that, again, is the future. We're working to disseminate best coding practices, and again, the Gestational Age Toolkit will be very helpful here. Ohio's working on this as well, and we're sharing back and forth between California and Ohio. I think, sort of as an adjunct to systems change, is you have to look at data as a QI project. Just like you do a clinical QI project, and applying QI principles to improving the completeness and accuracy of the data. So we are generating, with our real-time data, missing data or inconsistent data reports. So we have data from a birth certificate and data from patient discharge diagnosis files, and they say different things. We can point that out to the hospital that somebody's not right here. I don't know which one it is, but someone's not right. And then lastly, as I mentioned before, you have to have some value in maternal data for the hospital. They'll only improve it if they have skin in the game. So you want to be able to use these kinds of data for QI reporting and for public reporting. And then hospitals are going to invest money in improving the data. So we have a demo of what we've done in California that people are welcome to visit. No passwords required. There's some screenshots here. This is a sample hospital with jumbled data, so it's real data from real hospitals, but it's all interspersed, so there's no identifiers. So we have a set of quality measures, general maternity statistics and data quality, are able to graph it and compare it to state and regional averages. Importantly, though, you can drill down on any of these spots. And you can compare and download the measure as the image or so forth, but you can drill down and then see individual patients No identifiers here, but you can see why you fell off if you're an active person. This is done, only the hospital sees this internally, but this helps you drive quality improvement. So we're taking just the measures a step further with tools that allow you to analyze your own data, sort of a QI in a box, see where your errors are or where your opportunities to improvement are at the case level, and then drive the quality improvement. So here's another example of that. So this is a series of sub-measures, internal benchmarking of what's driving your elective delivery. And you can ask questions, is this about C-sections or about inductions? How good is our coding? Are we overcoding, undercoding? There's measures under that. Provider level measures, you can see who in your hospital has having the biggest impact on this measure. And lastly, this is the interesting one for me, are we actually reducing the number of 37, 38-week births, or are we just doing a better job of relabeling them? Here's a list of data quality reports that we generate. This hospital had actually a fairly sizable number of inconsistent delivery methods. And this was largely on the birth certificate, where birth certificate said vaginal delivery and the PDD said a C-section. And that shouldn't occur. And most hospitals are pretty close to zero, but some are a couple percent. So we can point out, we can identify the hospitals that have inconsistent data and focus the QI on them. So again, the website's available for review. Please go there. If you're in California, sign up for active participation. And we're working with some other states to do some like things. So summary here is that these are now front and center. The Joint Commission and NQF and CMS are rapidly moving toward mandatory reporting on these, a number of these metrics. I would like to add, though, that developing new metrics is really hard work to develop and validate and do reliability testing. So don't expect many brand new ones out there beyond the ones we talked about today that are under testing. I think there's opportunities, but it takes 2 or 3 years easy to go through the pipeline. I think if we're emphasizing clinical quality improvement, we need to match it with an organized approach toward data quality improvement. And then everybody can be comfortable with the data that were out there. We also have to have a parallel project for physician documentation, either EMRs or structured forms or something to have a little better data on the first page to begin with. So with that, I'd like to stop and address questions. We have about another 12, 13 minutes.
Hi, Ellie. This is Kiba. Before we open up for questions, I'd just like to remind participants that handouts for this presentation are available and can be accessed through the link at the top of your screen on the right. It looks like 3 pages, this white pages link right before the feedback icon. If you can click that, you select the presentation and then click download. You can download the handout for this presentation. I'd like to ask the operator to open the lines for questions. We have about 10 minutes for questions at this time.
Thank you. At this time, to ask a question, please press star followed by 1 on your touch-tone phone. You will be prompted to record your name. To withdraw your request, you may press star 2. Once again, that is star 1 for any questions or comments, please. As a reminder, for any questions or comments, please press star 1 on your touch-tone phone.
I'd also be curious if other states are undertaking these types of activities, and if there are comments to be made. I'm happy to hear those as well.
I do have a question from Karen Watts. Your line is now open.
Oh, thanks. Hi. Thank you so much for such an informative briefing. Unfortunately, we weren't able to get in on the website. How can we get your slides? Because we can't click on that link.
So I'm going to turn that to Kiba.
So the presentation will be made available on the web page. So you're unable to access the live meeting web page, is that correct?
Yes, that's correct.
Okay. And also when we send, we'll also be sending opportunity to give feedback after the presentation. If you had problems getting on or if you could not access any part of the presentation, you can let us know at that time and we can make sure you get handouts.
So Kiva, when you send that feedback request, perhaps you could add a link to the site at the CDC where the slide set is.
Yes, I will. We usually provide access to the actual web page, our web page as well.
So, and I do have another question on follow-up. I know a lot of the information that you gave was hospital-based, and looking at those issues, can you talk on how it transfers into the public health and how we can do a better job of helping our constituents improve and get knowledgeable? Now, I know they're reportable for 39 weeks, but still there's going to be women out there that want to have their baby, and that's going to all come down to education. So is that anything that's being followed?
Sure. There's a whole lot of things going on for perinatal quality improvement that involves the public directly, as well as working with providers at the hospital level. The March of Dimes has been the big lead in many states on public awareness, both with PSAs, with handouts. There's a number of tools that they've developed that are actually quite effective, both for providers to hand out in clinics or in offices, and in WIC programs, for example. I think WIC is an opportunity for some education on some of these issues in particular that is run typically by the State Department of Health. A number of these measures do roll up into statewide measures or regional measures. In California, we directly engage the Department of Public Health as a full partner in all these activities and work with them with their regional perinatal programs, which I gave you, the slide showed how we're regionalized, but we have typically a nurse from perinatal nurse that's in charge of each region in terms of coordinating what goes on for education and for drawing the hospital's attention to the QI efforts, the QI tools, and the QI measure outcomes. One aspect of public health is rolling up all the activities that occur clinically. That's a limited view of public health, I recognize. But I think it's trying to have a place of engagement for the provider side and the public health programs, so they're all sort of pulling the oars in the rowboat in the same direction. And so I think everybody needs to be aware of these measures and to see where they can fit in. I hope that's a start, but these kind of projects take everybody in every angle you can think of. This is like changing the course of a supertanker.
Great. Yes, I totally agree with that.
Thank you. Our next question is from John Esslinger.
Hi, I just want to say thank you for a great presentation. I think sometimes it's a challenge to be aware of all the activities that are going around in terms of trying to measure and improve the outcomes in the perinatal arena. So just wanted to tell you, greatly appreciate it. I thought this was a very outstanding presentation.
Thank you very much. It is a challenge. It's almost become my full-time job, but I still see patients. But this is the biggest challenge we have, is to create an agenda and to have everybody pulling in the same direction.
Thank you. Our next question is from Deb Walk.
Yes, my question, and thank you for the presentation. I found it very informational as well. Where can we find the list of the birth trauma ICD-9 codes? There
are two measures. that I spoke of. One is the ARC measure, which is called birth trauma, and that's PSI 17. So that's a safety measure, and that's, if you Google PSI 17, you'll find the codes for that. That was not endorsed by NQF and really shouldn't be largely used because it has a number of codes that are birth injury not otherwise specified, which ends up being, in ICD-9 language, basically a place you put all kinds of things. The healthy term newborn measure that I spoke of is, we've just done the final tweaks, and it should be up on our website with the latest set of ICD-9 codes and the full directions. Give us another week. And that would be at CMQCC.
All righty, thank you.
CMQCC.org.
I think you have time for maybe one or two questions left.
I'm currently showing no audio questions.
Okay. I just want to remind participants also that the handout is available. After the presentation, we will be uploading the recording for this webinar on the CDC webpage, and I'll give that webpage again. It's www.cdc.gov/reproductive health/maternal infant health/PQC. Those who have registered for this presentation will also receive further communication from us regarding feedback. We would like to thank Dr. Main for giving us an excellent presentation of perinatal performance measures. We would also like to thank you all for participating in this webinar and invite you to join us for our next presentation in April, which will be on building and sustaining a collaborative. We would appreciate any feedback you can give us on this webinar series, and we'll be contacting you after this webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. To help accomplish these goals, we plan to list active collaboratives and provide contact information on our webpage. We encourage you to visit the webpage and to submit information for your regional or statewide collaborative so that you may be included in this effort. You can contact us at the DRH info link at the bottom of our webpage. Thank you again, and good afternoon.
Thank you. This does conclude today's conference. Thank you very much for joining. You may disconnect at this time.